Hello and welcome everyone to this episode of the Trauma Anesthesia Society podcast, focusing on emergency preparedness, mass casualty topics. We're delighted to have Dr. Nakul Raykar with us of the Blood Desert Coalition. He's been doing some remarkable work with the coalition and otherwise, and we're delighted to have him with us to talk about this very important topic. Uh, Nakul, would you be so kind as to introduce yourself and some of the work that you've been doing, as well as what titles you hold, and then we can jump straight into this fascinating conversation.
Yeah, that sounds awesome, Herman. Thank you so much for having me. And as you said, my name is Nakul Raykar. I am a trauma and emergency surgeon at Brigham and Women's Hospital in Boston, Massachusetts. I do a few other things in the hospital between co-directing the surgical intensive care unit and am also the fellowship director of the Harvard Medical School Program in Global Surgery and Social Change, which is, of course, very much related to all of this work. Um, and as you said, we started the Blood Desert Coalition about 2 years ago now, and have been actively growing membership and focus and scope and breadth of the projects involved, and very much looking forward to chatting about those things.
Thank you, Nakul. We're also really pleased to have a live audience with us who will have a chance to ask questions towards the end of our conversation. And I ask them when they do ask questions to just very briefly introduce yourself in one line as you ask those questions. Nakul, to start, uh, for a person who's never heard of a blood desert and who doesn't know much about blood transfusion world in general, how would you describe a blood desert? Can you just define the problem for us and what it means?
Yeah, it's a great question. So the human body requires blood, right, to function. And I think that's something all of us understand. And I think we also all just by our experience in life recognize that when we are injured and we bleed, there's a very high risk of death. And so hemorrhage, which is the medical term for people bleeding a lot and bleeding very quickly, is a very deadly condition. And the treatment to hemorrhage is two things. One, we got to get you blood products as quickly as possible. And the second thing is we got to give you the right mix of blood products as quickly as possible. And so there's some nuance there, but typically giving people, what we call whole blood or an approximation of whole blood with red blood cells and platelets and plasma and sort of that whole mix is really important. Unfortunately, whether you're going to have access to those treatment modalities or not depends entirely based on where you live. And so there are parts of this world where access to transfusion is severely, severely limited. When we look at this issue globally, there's a great paper and a team that put out a study in the Lancet Hematology in 2019 that looked at availability of blood products globally, and they found that there was a 102 million unit shortage of blood products across just low and middle income countries across the world.
Mhm.
Every single country in sub-Saharan Africa, in South Asia, and Oceania was in deficit. That means that they didn't have enough blood to be able to meet treatment needs of their population. But we are talking today about a problem that's much worse than deficit. Deficit is when you need 3 units of blood for a particular patient and you can only give them one, right? Or you only have a limited supply. What we're talking about in terms of blood deserts is the complete absence of blood.
Mhm.
And there are lots and lots of places around the world where you may have a healthcare facility, but there's no blood bank attached to that. So you might be able to get some clinical care, but to get a blood transfusion, the closest blood bank is hours or days away. And we consider that sort of concept a blood desert. where if you present to a blood desert with hemorrhagic shock, um, or a severe bleeding issue, you are out of luck. And it's a tragedy. It's a tragedy, right? Because most of the time, hemorrhage after whether it's trauma or obstetrics or it's related to, or if it's related to an anemia, right? A severe anemia,
Mm.
pediatrics, oncology, GI bleeding. These are fixable problems, and definitely can be stabilized with transfusion. And so we're
Mm.
not talking about, the margins of medical efficacy. We're talking about if you get a transfusion, this patient will be alive. And if you don't get a transfusion, this patient is almost certainly going to die. And so it's a real problem.
Thank you for painting that picture and the figure that you mentioned, 102 million units, in a way we could say missing, is really an alarming number. I, we would love it if you could paint a picture also in terms of an incident when what does it look like if a patient, whether it is around childbirth, if they have a bleeding issue, or if they've been in a traumatic accident, for example, shows up to one of these facilities in either of these countries where you mentioned the blood desert issues are quite significant. Uh, how much time does it take to get blood? What even does
Yeah,
that look like? Whether there's absence of a blood bank at that facility, or what is the timeline? Just give us an example, if you would.
I'll I'll tell you a story. This is unfortunately a very true story, but I think it illustrates the issue really well. So, um, a lot of my work, we're doing a walking blood bank implementation study in northwest Kenya, Turkana County. Turkana County is a uh, beautiful place. It's also a really hard place to live and a really hard place to work and deliver healthcare. Um, it is a both a physical desert with temperatures well above 100 degrees on
Mm,
most days, as well as a blood desert. And so Turkana County is also considered kind of the cradle of humanity. There's a saltwater lake in the middle. It's enormous, called Lake Turkana, and some of the oldest human remains, skeletons, have been sort of found in that area. And one of the so right on the banks of Lake Turkana, modern day, is a clinic in Nariokotomé, which is sort of a very rural primary health center outpost. And so a few years ago, on New Year's Eve, a patient, her name was Ernestina. She was 23 years old. She's just a pillar of her community and her society, adored by the elders and the youth alike. Um, Mother of two. This is her third baby she's now pregnant with, and she shows up to this clinic in Narikatome in extremis. She's not doing well. She's diaphoretic. She's kind of she can barely walk. She
mm,
she looks terrible. And the clinicians at this facility very correctly recognize her as someone who's in obstetric hemorrhage
mm,
and who's bleeding. And they send tests, and her hemoglobin is 3.
mm.
Um,
Wow.
Recognizing the urgency of the situation, they and the fact that they can't treat it there. There's no blood at the small clinic in Narikotome. It's about 4 to 6 hours away from Lodwar, which is the capital of Turkana County, and it's and the seat of the main referral hospital. And so and that's best case scenario if you had a car or an
Mm,
ambulance. They don't at the moment, but somehow they're able to sort of get her over to Lodwar County Referral Hospital very quickly, all things
mm-hmm.
considered. She makes it to Lodwar County Referral Hospital, where they do have access to blood transfusion, but there is no blood. And the reason for, there's some complexity and nuance we'll discuss later, but essentially a lot of the transfusion, they collect blood, but they can't test the blood there, so they have to send it out for testing, and they have to wait for those results to come back. And so you might show up and there might be blood in the blood bank, but they can't technically give it to you because they're not sure if it's free of HIV and hepatitis yet, and they're waiting for
Mm,
those test results. So Ernestina makes it to Lodwar County Referral Hospital, and they're waiting for testing results um, to give her blood. And she waits 1 day and 2 days and 3 days and 4 days. On the fourth day, both the patient and her family are getting really anxious and frustrated, and the providers who work at Lodwar County Referral Hospital are too, right? This is a
mm,
horrible source of moral anguish when something like this happens. And so they all kind of are like, okay, we just got to transfer her to the next hospital, which is now 8 to 12 hours away. It's in Eldoret. And so they arrange for transport. She gets there. This is now day 5, and they are arranging her for blood transfusion. But by that time, it's too late. Okay, so
mm,
both mother and baby dead. Um, and so I think about this and I say, why did Ernestina die? Right. And it's some people will say, on first thought, you say, oh, well, she died of obstetric hemorrhage. She bled from,
mm,
some complication of pregnancy. But that's not true, right? She did not die of obstetric hemorrhage. She died from a lack of blood transfusion. And that is, and proven by the fact that she survived for 5 days. We had 5 days and to get her transfusion, and we, as a health system, were unable to do that for her. And that I think that kind of captures for me what like life in a blood desert is, right? Like, there's no way Ernestina would have died in a context where there was blood available at the facility in Narikatome or at the facility in Lodwar, which there usually, there should be, but it wasn't available at the time.
It's a harrowing story, and something that sitting in the West is hard to imagine because we take it for granted that especially for obstetric hemorrhage and most traumas, blood would be available. But I think it's a great way to illustrate the real human cost of the issue, and maybe we can take Ernestina's case that even getting to Lodwar facility, which was in and of itself not guaranteed that everyone can. Now,
100%. Right.
with the Blood Desert Coalition, when did you have, or did this group have the idea of starting this coalition? And taking this example, what are the primary interventions that could have changed the outcome in Ernestina's case?
Really, really, really good question. I'll answer that in two ways, which is that uh, the headline is, yes, this is a very fixable problem. The solutions are out there, right? Um, I'll also preface that by saying um, it is it is no surprise that blood deserts exist, and that's because blood transfusion is a complicated process. It is not straightforward. There's an entire specialty of medicine devoted to the transfusion of medicine and all the complexity and the logistics that goes around with that. And I, for one, I'm a surgeon now. I was a surgical resident I was a surgical resident in the past. And during my training, and I did my residency in Boston. I did my fellowship in Pittsburgh, and then I've come back to work in Boston. Throughout this journey, it is very possible to not recognize the value or just what a precious resource blood is. And I think that's true across, our both of our specialties, right? In anesthesia
Mhm.
as well. If you train in a high resource context, you use a lot of blood, but it's always there, right? And I remember that. I distinctly remember that feeling in the trauma bay when I was a third year resident. And there was one time where, it was taking longer. We had a trauma patient, very sick. It was taking a little bit longer for the blood bank to send the right units for that patient. And there was that source of frustration. It was like, I don't understand. Why can't we have blood right now for this patient? We need it now, like not 10 minutes from now. And of course, like it's not that simple. That patient and antibodies or something, and they were trying to figure out the right, a safe transfusion
Hmm.
um, product for the patient. Um, but it wasn't until I was a surgical resident doing my global health fellowship, which took me to sort of very rural parts of the world. We were part of this project called the Lancet Commission on Global Surgery.
Hmm.
Um, and so I had a chance to kind of meet with frontline surgeons all over the world. Some were practicing alone, some were practicing in different sort of groups in different practice environments. And the Lancet Commission on Global Surgery said, was looking at kind of this global landscape of surgical care, and how do we improve surgical care, and why is it not available? And one of the core findings was that almost 70% of the world's population doesn't have access to surgery. It made a whole bunch of recommendations on what you got to do to improve that, and talked about infrastructure and workforce and information
Hmm.
systems and financing. And everybody that I talked to said that that's great. Nice report. Makes a lot of sense. If you want to build 1,000 new hospitals, um, yes, you have to do all of those things. But there are so many of us who are practicing right now, functional hospitals, where we could do so much more. And the reason we're not doing more is we don't have blood, right? That's why
Hmm.
we're not operating on that complicated patient here. That's when that patient who presents in hemorrhagic shock or is bleeding in any component, we're not going to treat that patient at all here because we can't do anything about it. We're going to send that patient and refer them right away. Um, and and that sort of crystallized in me sort of this recognition that wow, like blood, even having a blood bank, a functional blood bank, is such a privilege,
Hmm.
and it's something that I don't think. I mean, why would we think about it? We don't think about it, right? Practicing in a high resource context, and it's something that we need to recognize when we're working in spaces outside of this, that that there are adaptations that are made every day to deal with that. And so trying to recognize that there are um, other ways of doing things, and some of the frustrations for why surgery doesn't happen, or trauma outcomes are poor, or obstetric, maternal mortality might be high, is rooted in a lot of other things, and blood is a big factor for that across the world.
Yeah, thank you for sharing that. And Nakul, as you describe this issue, and the patient in the trauma bay that even in this high resource setting, you had to wait a little bit of time. If you could, as you briefly described the ideas and the initiatives and the modalities that the coalition has suggested, I believe there are three of them, could you also describe a little bit of what the problem is with getting safe blood and how that is addressed with each of these modalities?
Okay, it's a really good question. Sorry, Herman, I didn't actually end up answering your core question on the last answer. But yeah, so the Blood Desert Coalition. So back to what we were saying is that yes, situations like Ernestina happen every single day. Surgeons across the world highlight this as an issue. And I'm sure if you talk to, other specialties, they will tell you the same thing. This is a reality everywhere. So what can you do about it? Well, the surgeons in India, right, described to me a process back then, this about 13 years ago, and they said, well, I said, well, what do you do in this circumstance? Like you have a bleeding patient who's about to die. Um, how do you manage that? And they said, well, we're not supposed to, but what we do is we take blood from a family member, a relative, a healthcare worker, a community member. Um, we make sure that the types will be appropriate. and it's type appropriate. And then we'll test it using rapid diagnostic tests, so point of care kits. And I think after COVID, we're all very familiar with this.
Hmm.
It's you just kind of you dip it and you let a drop of blood kind of see what the result is. And we test primarily for four conditions. That's HIV, hepatitis B, hepatitis C, and syphilis. And if it's negative, right, and you do the appropriate cross match prior to transfusion, you can transfuse that unit of blood to that patient. And that's what they did in these sort of extreme circumstances to save patients. And the um, the challenge with that, they used to call that unbanked direct blood transfusion. So it's not from a blood bank; it's just direct from a community member, healthcare worker, family member to patient. And in many cases, these surgeons describe scrubbing out of a case, donating their own blood because they know that they have the same blood type, and
Right.
scrubbing back into the case for the patient. And so, this process is technically and still is not legal in India, and that's because of the concern over the risk of HIV transmission. So that it's a blood safety issue,
Right.
and they think that the rapid diagnostic tests, the RDTs, are not safe, right? That the sensitivity is not as high as if you do this through a formal blood bank, which uses either enzyme immunoassay or nucleic acid testing to kind of get a much better sense of in infection transmission and making sure that the blood is safe for transfusion. So that is, I think, the first. That was like a tip off of like, oh wow, like direct transfusion using point of care testing. That is a really promising way of addressing this if we can get around the safety issues, right? And so since then, and this is a process that they used to use primarily in the 1990s and early 2000s, and that's when it got, banned. The militaries across the world, U.S. military in particular, has done a lot of work on this concept of a walking blood bank. And when you look into what a walking blood bank is, it's essentially the same process, but it's kind of a pre-tested military pool. You send out all your soldiers, every soldier's blood type. If someone gets injured, there's a mass casualty event, which can happen with frequency in a battle scenario. You have a walking blood donor pool that can quickly transfuse blood to those patients, sometimes with rapid diagnostic testing, sometimes with no testing, because they're willing to take that risk in that emergency risk scenario. And so what
Sure.
we were thinking in through a broader sort of collective, and ultimately this morphed into the Blood Desert Coalition, is, well, why can't we readopt that practice and use that for Ernestina, right? It's the same situation. She's waiting for blood. She is going to die if she doesn't get blood. There's no other way to get blood.
Mm.
There are plenty of willing donors, whether that's healthcare workers or community members or people who are specifically mobilized, say, hey, we have an emergency, we need type A blood. Can someone come in? There are
Hmm.
plenty of ways of getting that in a community where there are people, there is blood, right? And so we should really never have a blood desert or a blood deficit. We have plenty of blood in any community. It's just a matter of getting the blood to the right people and through a safe process. And so this is, I think, what we need to do. And so this is what we call a walking blood bank, and what we're
Hmm.
now calling a civilian walking blood bank. And that's one of the four core sort of interventions from the Blood Desert Coalition that we are studying and hoping to implement, and can chat about the implementation project on that we're doing in Turkana, Kenya,
Right.
at the moment. The other three interventions, one is TXA. There's a medication out there. Anesthesiologists are, of course, very familiar with tranexamic acid, which is
Right.
an antifibrinolytic, and it's been around for a really long time, and it doesn't cost very much money. It's on the WHO essential medicines list. And technically, most hospitals in the world are supposed to have it on formulary. It's not actually true. A lot of hospitals don't have it on formulary, but it's pretty accessible and you should be able to get it. Um, And if administered in the acute hemorrhaging patient, it's very effective at kind of small vessel bleeding and at least minimizing blood loss. And in some cases, treating kind of internal hemorrhage in many cases. And so we need to have more protocols and a standardization of use of TXA. There's a lot of conflicting evidence out there, but I think almost everybody acknowledges that TXA use in the acute circumstance for bleeding patients in a blood desert environment makes sense. And so we kind of need to work on the implementation aspect of TXA. The
Okay.
third intervention is something that we call autotransfusion. So if you're working in a blood desert, you don't have blood, but you're operating on a patient to save their life
Hmm.
from a trauma, let's say, and let's say I have a splenic injury, we'll open a abdomen, right? And they have, 2 liters of blood in their abdomen from a spleen that has ruptured or from a liver injury. There's no reason you can't use that blood and recirculate it into the patient's own blood volume. We've been doing this for decades in the United States. Uh, it it's called autotransfusion, but there are specific devices. One of the more prominent devices is the cell saver,
Yes.
where we can essentially suction blood from peritoneal cavity, thoracic cavity, anywhere, and it filters and it transfuses back to the patient. In this context, there are now several companies that have come out with, and a couple more that are developing, um, built for the low resource context, specific devices that can help facilitate autotransfusion. And that, of course, you're giving a patient's own blood back to them. So a lot of the infectious concerns, HIV, hepatitis, you don't have to worry about as much. And so
Hmm.
it's a really nifty innovation, and but something that most people are not familiar with, right? And that's a collaborative sort of procedure between surgery and anesthesia. Both have to be kind of comfortable with doing that. And I think just general knowledge and comfort is very, very low. The fourth thing that we recommend or are actively looking into or advocate for is this concept of drone-based blood delivery. Drone-based blood delivery is, I think, pretty straightforward. We'll take it from one area, we'll fly it to an area that doesn't have blood. And there are several companies that do this. Zipline is probably the most prominent and has
Hmm.
been operating in Rwanda and Ghana for a long period of time, and with your really excellent results in terms of minimizing time to transfusion for a lot of patients, and also minimizing wastage in the blood system. Because if you're not using the blood at Center X, you can send it to somewhere where they need it right away, rather than that unit kind of expiring. And so that's something, and now there are at least 8 companies that I know about that are kind of developing this technology. A bunch of them are Indian companies that are using it
Hmm.
for the mountainous regions of the northeast in India. And so different models, different, ways to do that. Ultimately, it requires a little bit more investment. It doesn't fix the primary issue, which is that, you still need blood. And if you're employing drones in a blood deficient area, you're flying it from a place where you probably don't have enough blood to a place that doesn't have blood also. But in the acute case, a lot of these things are very useful, and you can kind of invest in systems to enhance blood collections in your hub sites. And so those are the 4 interventions: walking blood bank, civilian adaptation, TXA, autotransfusion, and then drone-based blood delivery.
Thank you, and thank you for describing them with such detail, because this is new information for a lot of our listeners, and it really shines such a light on these very doable interventions. Having gone to medical school in India, I've witnessed many cases of family members donating blood and using these rapid tests, and they have saved lives. Now,
Yeah.
uh, I have a couple of questions about each of these modalities, and I'm going to ask you somewhat of a more rapid Q&A about each of these. And let's take Ernestina's case. Now, she was able to survive for 5 days with a hemoglobin of 3. which is, for those not familiar with it, alarmingly low. Now, in her case, maybe her body and her health were different, but there are different categories of needs for blood transfusion. There are some that are immediate, there are some that are emergent and somewhat
Hmm.
less urgent, and patients that can survive somewhat longer. Now, when we look at these modalities, let's say in Ernestina's case, in either her immediate community or even at the Lodwar site, which is still far away, how would a walking blood bank be formulated, and what are the barriers there? And I'm sure there are country-specific barriers, but are there regulatory barriers or barriers in adoption? Let's start with the walking blood bank, and then we'll go through the list.
Yeah, that's perfect. And I'll try to be brief and perhaps uh, leave out some information, but we can probe it later. But I think that the short answer is that a walking blood bank could have saved Ernestina's life in Lodwar, right? She's transferred to Lodwar. We would have been able to mobilize donors, right? Rather than waiting an indefinite period of time for a transfusion to become available, right? Which we learned was not available in 4 days. Blood could have been provided to Ernestina within a few hours of her arrival in Lodwar's County Referral Hospital. The process would have been that the providers would have said, "Hey, we need blood now. Her hemoglobin is 3, and we don't have it. So let's contact other people. We'll test her blood type. Let's say she's A positive. We figure out who else has A positive blood. We can contact a list of regular donors um, who routinely donate to the hospital and have a positive profile. Call them in, or healthcare workers who have the same. Get that blood, test it using rapid diagnostic tests, and
Hmm.
then transfuse it to Ernestina. The big barriers are that there is still a lot of stigma around the concept of using point of care rapid diagnostic testing. And it's um, completely unnecessary. And so we started in 2022 the Lifeblood study in at Lodwar County Referral Hospital. It's called the Lifeblood, is an acronym for Local Initiative for Emergency Blood.
Hmm.
And it is a walking blood bank implementation trial. And we looked at this and kind of said, hey, would this walking blood bank concept work in Lodwar or in a setting like this? And what we found, right, was, well, what do you need to do that? Well, you need rapid diagnostic tests. You need people who can use it and know how to use it, and then people to make that decision and do it. And what we found from the clinicians on site was that they already did it in sort of extreme circumstances. When a patient was about to die and they didn't have an option, they would
Hmm.
often do this. But they were worried, right? They were worried that they would get in trouble. They were worried that it's technically there's no explicit, you know, directive saying you can do this.
Hmm.
And they were told that the rapid diagnostic test had a high risk of HIV or hepatitis C transmission, right? Or hepatitis B. And so they were worried that they were maybe giving somebody a blood transfusion, but they were also going to give them a lifelong illness that is going to also cause issues. And so what we did was we tested 800 samples of blood collected at
Hmm.
Lodwar County Referral Hospital with rapid diagnostic tests that were available at Lodwar County Referral Hospital, and compared it through the standard of care blood testing process in Kenya. And what we found was that there was a 99.2% negative predictive value of blood tested with a rapid diagnostic test. And the reason for that is that the fifth generation, the latest generation RDTs that you can buy in the market, see, in the 1970s and 80s and 90s,
Hmm.
your RDT sensitivity was like 80%, maybe 90% if you got lucky. Now they're all like 98, 99,
Hmm.
99.5% sensitivity. And so the risk of, a lot of the concerns that, people have about RDT quality are rooted in a much different context. And so we
Hmm.
presented that to the Kenyan authorities. The Kenyan National Blood Transfusion Service, as well as the Ministry of Health, authorized a trial basis emergency transfusion protocol, walking blood bank in
Hmm.
Turkana, and so that's what we're doing. I think the barriers globally are the same. There's a lot of misinformation about RDTs, and we need to sort of tell people, hey, we can do it, we can do it safely, and
Hmm.
of course there are risks and benefits, but when a patient is on the verge of death from lack of transfusion, the decision making is pretty straightforward, right? It's near certain death or maybe HIV or maybe hepatitis, all of which are treatable in the long run in 2026.
And you would think that with a 99.2% negative predictive value, these RDTs or rapid diagnostic tests should have more acceptance in the medical community. And I'm going to ask you a couple of questions about the other modalities, and then I want to ask you about some when you go to policymakers with this data, and also to counter the misinformation among clinicians who are making these decisions, what you encounter. Um, the TXA, you described that protocols and implementation of those protocols is necessary. When it comes to auto transfusion, you mentioned some companies have made low cost alternatives. Can you give us one example? Because the cell saver that you mentioned that we use in the United States is expensive. It
Very
requires
expensive. Yeah.
requires reliable electricity, and of course can save lives. But can you give an example of a product and what obstacles there might be in implementation, and what major differences there are in safety among these low cost products and something like a cell saver?
So auto transfusion has been around for a long time, even before low cost devices came about. It's been used in a low resource environment for a long time, and there's some great papers out there that describe the technique, which a lot of colleagues who work in low resource environments use but don't write about. But there's this one beautiful paper that talks about a scoop and ladle approach, which
Mm,
essentially, you scoop blood out with a soup ladle and you dump it onto a stack of gauze about this high, and you just kind of let it trickle down. Whatever trickles down, you collect and then you transfuse
mm,
back to a patient. There are now much more standardized ways of doing this, and one is a device called the Hemafuse by a company called Sisu Global Health. I don't not endorsing the product, but I think
mhm,
I from a we do work with them from a Blood Desert Coalition standpoint because it's the only uh, product that's actually on market, that's standardized and very low cost. And so we do think that this is an avenue to kind of save lives in this context. But it's really designed for extreme low resource environment. It looks like a big plunger slash syringe, and you can literally just kind of pull the syringe back, scoop up a big volume of blood, and then there's a stopcock on it, and you can kind of turn that, and then you can
mm,
squeeze the blood out through a different valve that goes through a filter, which
mm,
filters the blood and puts it into a blood bag, which is then handed off to the anesthesiologist, who can then transfuse it back to the patient during the same case. Um, there's a group in India that's creating a very low cost version of this, which effectively is uh, uses gravity and a bunch of cardboard boxes, and of course
mm.
blood bags and tubing to sort of filter blood out of a body cavity, put it into a blood bag, and then similar sort of circumstance. Main barrier, I think, this is very much within the clinical domain. The main barrier, I think, is just sort of comfort. It's not something that you teach, or most of us learn in medical school, even in a lot of low resource contexts. It's just not in the textbooks. But it's a clinical practice that people have been doing for a long period of time with a pretty well established safety profile. And again, in the circumstances in which we're using this, it's not really it's a matter of life and death, or death, near certain death without a
Mm.
transfusion. And so, that risk benefit always needs to be revisited. And so I think for auto transfusion, it's a lot of it's just lack of knowledge that's our biggest barrier.
It seems like a technically simple but a very effective solution to give filtered blood back to the patient. Now, this device you give an example of, does it need electricity? Because I know that can be an issue,
It can be an issue, and it doesn't require. It's a very manual mechanical process.
which in itself is so beneficial in some of these settings. Now, a highly technical solution, which is the drone-based delivery, which requires a hub and delivery to areas where otherwise getting blood to might be more difficult. Can you give us one short example, and then I actually want to open up to some questions of where you've seen it be most effective? Like, what are the infrastructure or geographic or other context specific factors that make it an effective method of getting blood where it's needed? And also briefly, um, does it not? It's an issue sometimes with these interventions that it actually reveals a lot of unmet need in areas that might not have expressed that need before this modality was available. So if you could talk about both of those briefly, and then I'll open to
Yeah,
some questions.
absolutely. So I think if you're planning a health system and getting blood coverage to numerous facilities that are sort of just outside of range currently, with long transport times between your blood collection center or hub and these other facilities, and you don't have the ability to implement blood collection centers at each of your facilities, then drones are a great way of taking blood and really centralizing in these centralized processes and distributing it out. And it works really well, at least the system that they've set up. I'll give the example of Zipline in Rwanda. They've done a fantastic job. And, if you sort of visit a lot of some of the sites that both receive blood as well as the sites that dispatch blood, it's a fairly seamless process, right? You ask for blood, the the request is transmitted to the central location. They get it instantly. They usually dispatch blood within a handful of minutes. And the blood gets to you at 30 to 40 minutes later, depending on how far away you are, right? And it drops it right outside, and you go and you pick it up,
Mhm.
and you can go ahead and use it for your patient almost immediately. And so that is, I think, that is, I think that's the power of that. And I think it works really well in places that your facilities are up in the mountains or your road access is going to be poor. But you just had, massive rain, and now the roads are not what they were before. You can't send an ambulance up there. And so it sort of eliminates a lot of that stuff. And I think that even in places like the United States, we rely a lot for emergency circumstances of air transport, of ambulance transport, of getting people from one place to another. And that's not without risk to airline, to our ambulance crews, right?
Mhm.
Especially when there's bad weather. And drones, of course, offer the unmanned advantage, right, of not, putting a human flight crew at risk. And so it really, I think, does offer some advantages in that area.
Mhm.
Barriers, of course, are cost, but I think we need to kind of relook at how we view cost. I mean, sure, there's a cost associated with that, but there's also tremendous costs associated with everything that we do in healthcare and beyond healthcare. And really, what's the benefit? And if the benefit is that we're able to uh, provide not only save the Ernestinas of the future, but we're also able to support uh, the the morale of clinicians and providers who are spending their lives working in very difficult clinical environments by
Mhm.
saying, "Hey, we got you. If you need blood, we're gonna make sure that you don't have to deal with that circumstance." I think it's very, very, very beneficial.
Thank you, Nakul. It really seems so. And one last question from me before we open up to questions from our attendees. Eh, are blood deserts just a low and middle income country issue? Like, are there blood deserts in high income contexts? And also, do these issues pop up when these higher resource settings are in a mass casualty or emergency setting, where one could assume that the modalities that you mentioned and the interventions might become useful even in this setting. I'm sure some of our attendees will have similar questions, but could you address that for a moment before we open up for questions?
Yeah, absolutely. So I'll say, we know that in the United States, outcomes from trauma, outcomes for maternal care, right, are worse in there are differences in outcomes when you look at sort of areas of healthcare concentration versus relative lack of healthcare resources. And in the United States, a lot of that it divides pretty cleanly along urban and rural sort of contexts. And so we know that people who have bleeding conditions tend to do worse in rural. So how much of that is could be related to lack of blood access? It's hard to
Hmm.
know, right? Um, so if you look in the literature, there are a few very telling papers that reflect what you would hear if you talk to a lot of our rural colleagues who practice in different environments across the United States, is that yes, we do have circumstances where patients will present to a hospital and we don't have the blood resources to give these patients and at the time that they need it, and that our only options end up being transfer, which takes a long time. And then, we're at the same fate that Ernestina is up to, which is that transfer and hope that there's a better outcome, that you make it to the transfer center and that there is a better outcome there. So there's a great paper by Dr. Nunez Argote and team from Kansas in the American Journal of Clinical Pathology 2016, 2019, something like that. I can't remember. Or it might be more recent than that. But they looked at critical access hospitals in the state of Kansas. They found that 20% of critical access hospitals didn't have any blood products in inventory, right? Think
Wow,
about that. Didn't have
20%.
any 20% didn't have any blood products in inventory. And it's a cross-sectional study and maybe this
Sure.
varies with time, but at the time that they did it, 20% didn't have it. They found that about 30% did not have a 24/7 blood bank or the resources to sort of to staff a blood bank, even if they did have those components of that other 70%. And most critically, when it comes to platelets, right, only 3% of hospitals had platelets to be able to transfuse. And we all know that platelets are a critical piece of balanced resuscitation to treat hemorrhagic shock. You can't do it, right, without platelets. And so a big swath of our population might not have access to the best of hemorrhage uh, trauma hemorrhage management, right?
Mhm.
If there are no platelets. And platelets are really hard. I mean, we have platelet shortages all the time in my hospital, in, one a big academic center, big city in America. And you can only imagine what the issues are. And I think that Kansas example of 3% is probably true for a lot of places because platelets are really hard. The shelf life of 5 days. By the time you send it out to somewhere, it's time to send it back somewhere else to get it, used. Otherwise, that platelet is going to be expired. And guess what? Even the big centers have platelet shortages. So you don't want to risk sending that out to a critical access hospital that might not use it, and waste that resource. And so there's a significant tension there. And I anticipate if we study this in any structured manner, we're going to find significant vulnerabilities when it comes to supply demand mismatch, right? It might not be a blood desert where there's no blood products for hours and hours on end, but there might be a lot of areas where we can't either do timely transfusion or balanced resuscitation, which I think are the two components of hemorrhage management that we care about most.
Thank you, Nakul. I mean, you've enlightened us on this topic, which I know is very much in the awareness of some of our attendees in our live audience today. Um, Many of our anesthesiologists who work in trauma, and we'll start with some questions from them, if that's all right. I see Jason's head up. Jason, if you could please unmute yourself, introduce yourself briefly, and then ask your question.
Yeah, thanks, Harmon, for moderating this session, and thanks, Dr. Riker, for a great talk. And uh, by way of introduction, Jason Gillihan, I'm a professor of anesthesiology at Washington University in St. Louis, Missouri. I'm currently the president of the Trauma Anesthesiology Society. I want to pull the thread a little bit more on the walking blood bank and your answer to that last question because it was a perfect tee up for where I wanted to go. And that is, I've spent, portions of my career in the military, working in, very low resourced areas and overseas deployments. I've been in critical access hospitals. I work currently at a large quaternary center that has everything, that I could want in terms of whole blood and point of care testing, et cetera. So I've thought about all these, variety of different scenarios, and I think you make a very good point. Is that we can oftentimes be challenged in every one of those environments, just in different ways. Um, as I look back on my military experience from very early on in the mid to late '90s, we were doing, blood type testing with use of Eldon cards, and
Mm,
that still serves as a very reliable way of testing blood type. And as we looked at how we prepared for deployments, we had an annual testing requirement for HIV and hepatitis among all the service members. And you would do that again in the immediate weeks or months prior to a deployment in preparation for having that walking blood bank capability of your service members. And I wonder in some of these areas, both, overseas, low resourced areas, or even the rural area that you speak of, because I've definitely lived that with the critical access
mm,
hospital experience of using almost a civil service type model where you have pre-identified personnel, kind of like you spoke about, not just in the hospital, but in your community, who would subject themselves to some regular frequency of testing for those bloodborne pathogens. We would have their blood type on file, and you would have a reliable source of blood donor availability within your community, and maybe that awareness of the fact that those individuals volunteer and subject themselves to that regular testing would also enhance the community's acceptance of the risk of those blood products being donated by those individuals. What are your thoughts on that?
I think you've captured the essence of this issue and the solution perfectly. And thank you so much for sort of bringing in your military experience because I think it highlights a really critical point here, which is that are not these are not new crazy ideas. These are things that have been tested and people have done and the US military in particular has gotten very, very good at doing. And now we just need to kind of apply some of the benefits of what we've learned to the civilian context. And I think your point about having pre-screened donor pools amongst the civilian population, civil society leaders, or others who would readily donate in a rural community to other people in their community if there were ever a tragedy is absolutely the next step that we need to do. This is exactly what is happening in Turkana County, Kenya, at LCRH. But I think it is exactly the model that we would use here in the United States. There's a South Texas regional advisory committee, I think. STRAC is the title, and they have a program called Heroes in Arms, which is it's a whole blood donation system that people can then use in hospitals and pre-hospital setting. But if it ever came down to it, as a resilience measure, it could be activated in exactly the manner that you described. That we have an emergency, we don't have enough blood. Now all of you people who are coming in for periodic donations, can you come like today and give us X amount of blood that we can then use in this crisis scenario? Um, I'll add one more point, which I think adds to your point of sort of communities in rural environments, sort of being the backup for themselves, right? Because they can't rely on this broader system. And what highlights that the most to me is that the U.S. military, right, has told people, including the American College of Surgeons Committee on Trauma, to prepare for that the U.S. trauma system has to be ready for to be able to handle the fallout from large-scale combat operations with a peer or near-peer adversary as soon as 2027. And the numbers they're talking about are that somewhere in the up to 2,000 casualties per day, making it back to U.S. Continental United States for treatment. We know from prior conflict that about 15% of soldiers who make it back to the United States need blood transfusion. Their average length of stay is in the 15 to 21 day range, and they usually need multiple transfusions over the course of that time, right? So look, I mean, 2,000 per month times 2,000 per day times 15% times however many median units of transfusion, that is a massive number, and that's going to be a massive strain on our blood supply. And so when that happens, and we're able to distribute all these patients to, to your quaternary center and the ones all across the country that can handle, trauma patients of this complexity, what's going to happen to the blood supplier who usually sends, 2 units to the critical access hospital so that they have it on file? It's not going to go there, right? They're going to send it to the tertiary center because there's an acute need and people are potentially bleeding. And so as a resilience measure, we need some sort of backup system. And I think walking blood banks are that backup system for when things go south and we have problems with blood sufficiency.
Thank
Thank
you
you,
so
Nakul.
much for expanding on that.
Thank you, Jason. And thank you, Nakul, for bringing that into the American context. And as you said, some intentions coming up in order to be ready, where the mass casualty or emergency scenario, a high resource setting can become something like a blood desert. I know Kevin's hand is up. If you're okay with going just a few minutes over, we'll take a couple more questions. Kevin, if you could unmute yourself and introduce yourself, please.
Yeah, hi, thanks. This is Kevin Blaine. I'm a trauma anesthesiologist currently in Portland, Oregon. Hey, so I'm very curious about the use of blood that's derived from a walking blood bank.
Mm-hmm.
I mean, you mentioned the point of care testing and that it's probably good enough, but almost by definition, it can't ever be better than the gold standard testing. That's why they require the gold standard testing, right? So there may be, it might be academic, but there's at least some risk to the blood that hasn't gone through the normal testing process.
Sure.
And we also know that not every transfusion that we give is necessary to save a life, at least not immediately. So
Yeah.
I wonder, do you think that blood that is collected under, should we say, less than ideal circumstances should be transfused under stricter clinical indications than blood that's collected through normal means?
Yeah. Great question. I think this highlights the central sort of tension of a walking blood bank and kind of the considerations around it. You're absolutely right? Like, there's a reason why we use nucleic acid testing. There's a reason why most centers use, why enzyme immunoassay testing was kind of the standard before that and still used in most of the world. And that's because it's reliable and it's high quality and it's the best we got. And the public expects very high quality, safe blood, which is free of transfusion transmissible infection. The walking blood bank, though, right, is not meant, right, and it's never meant to replace your traditional transfusion systems. It should never be the standard of care, so that at a critical access hospital in Kansas, that they don't stock blood and they only do a walking blood bank every time they need a transfusion. Hopefully we don't ever come to that, right? It should be a backup resilience measure, which is if you've got a patient who is bleeding and who is going to die if you don't have transfusion, or has a high risk of death or disability as a result of lack of transfusion, that you have an alternative to get blood when you don't have blood in your blood bank or within any sort of reasonable amount of time. And I'll give the example of what our protocol looks like in Turkana County, Kenya. Effectively, we call it the Walking Blood Bank Emergency Transfusion Protocol, and the first steps of those protocol is not even to use the rapid diagnostic test. The first step is to kind of do all the other things that you need to do to identify sources of blood, calling nearby center, seeing if anyone has any leftover blood that they didn't use, and figuring out kind of what other resources exist. And then if if it really comes down to it, you don't have blood, then there needs to be determination by the clinician, by the blood bank, by the patient and patient's family that yes, like this is a severe circumstance. We want to move through and forward with this process. And then you go ahead and you activate the walking blood bank, bring in donors, collect blood, and do that whole thing. And that whole thing can be anywhere from 30 minutes of time to about an hour and a half of time, but trumps the alternative, which is waiting on average, 80 plus hours for a unit of blood to become available through the traditional, testing process. So I agree there needs to be a very stringent use case. There needs to be standards around this. It needs to be protocolized. And it can't be just kind of a free-for-all of how we do this because there are risks to patients that we want to minimize. But we also need to recognize that there's a real risk of death in a lot of these clinical circumstances where patients are bleeding, and lack of transfusion because we're waiting for the most safe, blood to materialize from wherever we can get it is also a really unsafe option for a patient who's on the verge of death from hemorrhagic shock.
Thank you for that, Nakul. And Dr. Meera Gangadhar writes in the chat, and I'm also wondering the same. Is this a process where if there is a donor from a walking blood bank, that blood can actually be sent for the standardized testing, so that even if the patient is transfused with that blood, if something in the very rare chance comes up later, that the patient can be informed? Is this something in practice or can be?
Absolutely, and that is our standard process in the in our implementation effort in Kenya, which is all the blood, even if it is transfused. If it's transfused, it gets sent for standardized testing, and then we make sure there's a match. And if not, then we follow standard of care procedures to address that. And if you activate the walking blood bank, and this happens a fair amount of time too, you collect a whole bunch of units, but the patient is unfortunately expired before that, or their clinical circumstance has changed, and people are now like, actually, we don't need to transfuse this patient. Let's just see what happens. And now you have a few units of blood. You don't have to waste those units of blood, right? You can still send it through the traditional transfusion testing mechanisms and then wait for those results and then do with it what you would. So agree, there are a whole bunch of different design elements that can kind of mitigate this circumstance.
Thank you, Nakul. Do we have any more questions from our live audience before we wind up this conversation? Kathy?
Yes, hi. I'm sorry, I couldn't do the thing. My name is Kathy Marcucci. I'm actually, hang on one second. Can you guys hear me? Can you
Yeah.
hear me? So I'm an anesthesiologist. I'm actually also formally trained in there's my dog in hang on one second, in transfusion medicine. So I think your talk
Awesome.
is absolutely fascinating. Let me just make a couple points. In terms of cell salvage, you trained at Pittsburgh, so of course you know John Waters. And so can you guys hear me?
Yeah.
So I wanted to just make the point that John Waters did a lot of brilliant research and showed that salvaged blood is much safer than we thought 20 years ago. And you can use a lot more blood. You can actually wash laps. You can use blood from cancer patients. Sure, there's cancer cells in there, but it doesn't give cancer. You can actually use blood from septic patients. So that's a gigantic, and you trained at Pittsburgh, so I'm sure you knew, John, that's gigantic. Walking blood banks is kind of interesting. The problem for walking blood banks in the United States, and I trained at the NIH, which did have a donor center. I I don't know how it's going to fly in the US. In a low resource area, sure. But in the US, I'm not sure people are going to want blood that's not fully tested. What we were seeing is that people come in and they want blood that's tested for, the nth degree of stuff. They want blood that's from a donor who didn't have a COVID vaccine, right? So recipients' requirements are getting more and more stringent. I don't want I don't want somebody who ate this. I don't want blood from somebody who had a peanut allergy, right? And it's like, okay, we don't screen for people who ate peanuts. I don't want somebody who had a high fat meal, right? They want to know what's the lipid profile for this unit of donor blood, right? And so Americans are very sophisticated. I don't know how that's going to fly. And I'm talking like at the source, at the blood bank level. I think it's going to kind of be a little bit of a problem. But the final thing I wanted to let you know is that you have the exact right philosophical position in your work, which is that the aspects of what you're trying to do in Africa already exist in the United States. So blood is not safe, right? And it is not very well characterized. So, and there are things like when you give a granulocyte transfusion, that blood is not tested for TTVs, we call transfusion transmitted viruses, right? Because there isn't time, the granulocyte doesn't last very long. So you have this pool of identified donors and they come in and they give blood and then you test it after the granulocytes have been transfused. And so blood is very uncharacterized, right? So what you're giving is, I talked about this in a lecture, you're testing for two phenotypes, ABO and RH. There are 300 phenotypes that are untested, right? So Americans think they're getting highly evaluated and tested blood, and they're not actually. And so the trick is to just take the principles that we know, right? And then just, expand them. So you don't have to reinvent the wheel. You're on a spectrum that already exists. And I think it's fascinating that and you're so correct. And that you're like, this is not new. This is being done. But the one thing I think you'll have a little trouble with the walking blood bank because we are going in one direction, but the public is going in a different direction. So do you know Eamon Ferguson, actually? I need to make some introductions for you. Do you know Barbara Bryant? She does the walking blood bank in Antarctica and space and stuff. Do you know Barbara?
That would be a great connection. I'd love that.
Okay. She was
Um,
my boss at the NIH, and she's the head of CEO of Carter Blood Center. And if you haven't met her, she does low resource in the TM community. I need to put you guys in contact.
Fantastic.
Yeah,
That'd be
you
awesome.
have fantastic work, and good for you.
Thanks so much, and thanks for that, for those comments. I'll just really quickly address the kind of suitability of walking blood bank in the United States. Big barriers in the United States for sure.
Yeah.
In currently in early 2026, and I think one of the bigger barriers is, the most concrete barrier is FDA regulations that don't allow for. There are no RDTs that are on the approved list of
Right.
ways to transfuse
And
transfuse blood products.
remember, it's federal law,
Yeah.
right?
However, I'll say a couple of things. One is that, there also was never a documented need for this in the United States. Like we just haven't talked about this for a very long time, and now more and more people are talking about it. Entire communities are mobilizing around it. People are demanding that there is an improvement in sort of a safety and a resilience aspect to our health systems and our trauma systems in this country. And with that is coming new energy. So this is the first time that the American College of Surgeons is really mobilizing around a concept that there are parts of the country where trauma centers don't have access to the blood that they need, and especially if we're preparing for large-scale combat operations or some sort of mass casualty event, we're not going to be prepared. The second is the AABB, right, is also looking into this, and there are working groups that are being formed around the concept of walking blood bank. And so I think it is going to require a lot of sort of coordination and collaboration to sort of advance these concepts. And two, it's going to require a little bit more research. We're going to need to know kind of what is the situation. We don't have a single unified perspective of blood sufficiency in this country. which areas have too much blood, which areas don't have enough blood.
Correct.
We don't have a good way of documenting that, and nobody knows because it's such a fragmented system with so many blood suppliers and no
Correct.
centralized sort of process. So I think a lot of stuff is happening. I think there's a lot of momentum that I hope is going to help us get to kind of the solutions that we need to be able to make sure everybody's safe.
So, final thought. We have temporal blood deserts all the time. So, what most people don't know is most blood centers will collect blood every day of the year except for Christmas. And on December 26th, there's a little temporal blood desert for platelets, actually. There's a nor'easter in the northeast part of the United States, and the blood banks are empty. So I tell the story, final thought, let you go then. One time I was sitting down at the NIH, I called up the Baltimore, Washington Red Cross because we needed O blood. And they had only, for the entire Washington, Baltimore quarter, this is the Red Cross, only had 40 units of O blood. So the hospitals had blood, but there was nothing on the shelf backing them up. That's all they had for the entire 6.5 million people, right? So the deserts are already there. It's that the hospitals can't always see it. That there's nothing backing up the blood supply. There's no reservoir of blood or platelets. Zero. There's a 12-hour supply lots of times. So the deserts are there actually, but they're covered up maybe by a little puddle. Anyway, great talk. Nice to meet you.
Likewise. Thanks for that.
Thank you, Kathy, for those reflections, and I think you drove home the point that blood deserts are not uniquely a lower middle income country or low resource setting issue, and that they can show up even in higher resource settings in different ways. And with that, I'd like to thank Nakul. Mira, do you have a last very quick question? Because I see your hand up, and I'm afraid we will have to wind up soon because you've taken a lot of Dr. Raykar's time and for the sake of our audience. Mira?
I just wanted to say I think there are deserts and then the blood component deserts, like platelet deserts and RBC deserts, whatever. So I just wanted to add that. Thank you.
Absolutely. No, really important point. Absolutely. Platelets, huge desert, much of the country. Yep, absolutely.
I dealt with that just a couple of days ago with a patient who required platelets. And this is New York City and in a big hospital in New York City. With that, Nakul, thank you so much for your work, for this excellent conversation, for the work of the Blood Desert Coalition. We'll put a link to your website under this so that people can explore the work of the coalition and learn more, not just about your work, but also about the modalities and maybe get inspired either to get involved or find inspiration in their particular settings. Thank you so much for this conversation, Nakul. We wish you all the best, and thank you to our attendees. And I hope you all have a good rest of your day.
Thanks,
Stop
everyone.
the recording.
Take care, everybody.
Thanks. Great talk.